Hello, welcome to JSCAI's Conversation in Interventional Cardiology. My name is Daniel Chamié. I'm an interventional cardiologist and assistant professor of medicine at the section of cardiovascular medicine at Yale University, the director of intravascular imaging and physiology core labs at Yale, and a JSCAI section editor. And I'm honored to represent SCAI and JSCAI in this session. And we're here today to discuss an important paper that has been published in JSCAI, titled Coronary Artery Compliance Modification by Intravascular Lithotripsy, a new predictor of stent expansion in calcified coronary lesions. I'm joined by the presenting author, Dr. Federico Oliveri, which is an interventional cardiology fellow and PhD candidate at Leiden University in the Netherlands, and by Ziad Ali, who needs no introduction. Ziad is an imaging expert, one of the key researchers in coronary calcification, and the director of the DeMatteis Cardiovascular Institute at St. Francis Hospital in New York. So with that, I'll turn it over to you, Dr. Oliveri, and tell us about your manuscript, how you did your research, and what you found.
So thank you for this nice introduction. This is our manuscript called Coronary Artery Compliance Modification after intravascular lithotripsy. But let's start from the beginning. So what is coronary artery compliance? Coronary artery compliance is the ability of the coronary artery to expand and contract in response to change in artery pressure. As we know from physiology, the majority of the coronary flow occurs during diastole. However, from different studies, the cross-sectional area of the coronary arteries is greater during systole than diastole. So, but how can we practically and invasively check the variation of area or cross-sectional area of the coronary artery? So basically IVUS, we'll know, of course, IVUS is a live intravascular tool that allow us to measure area in systole and diastole, something that we cannot do in OCT because it's not live. In all cath lab, we have invasive measurement of artery pressure, so this is quite easy to estimate and to calculate the modification of pressure in systole and diastole. And this is the formula of coronary artery compliance. So the aim of our study was to answer to these three questions. So does intravascular lithotripsy improve coronary artery compliance? And is there any correlation between the incidence of calcium fracture following IVL and the modification of coronary artery compliance? So coronary artery compliance post and pre-IVL. Importantly, is there any relationship between coronary artery compliance modification and stent expansion? Can modification in coronary artery compliance predict stent expansion? So to answer this question, we use our Benelux IVL registry. There is a prospective registry ongoing of all-comer patients treated with IVL. From this registry, we took case where IVUS imaging was used, IVUS was used. We calculate, we measure the coronary artery compliance before intravascular lithotripsy. Later on, intravascular lithotripsy pulses were administered, and later on, post-IVL IVUS was run again. So modification of coronary compliance was the difference between post and pre-coronary artery compliance. Then lesions were stented, so lesion treated with drug-eluting balloon were excluded from our study, and measurement regarding stent expansion and eccentricity and so on were assessed. But we focus on stent expansion at the minimal stent area. So here are the results. So as you can see from these figures, there was a significant increase in coronary artery compliance after IVL, something that actually we'll expect it. And more importantly, importantly, as we can see, lesion presenting calcium fraction, macroscopic calcium fraction, greater modification of coronary artery compliance compared to lesion without calcium fracture. So basically, this is something that were suspected but not directly demonstrated. As you can see from these figures, linear correlation between the modification of coronary artery compliance and the stent expansion at the minimal stent area. And this is also consistent in the multivariate analysis. As you can see also, if we consider a lesion where stent expansion more than 80% was achieved, and the other lesion without this achievement was achieved, so you can see as the modification of coronary compliance was greater in the lesion where stent expansion were more than 80%. So to conclude, we can say that IVL enhance coronary artery compliance in calcified coronary lesion. The occurrence of calcium fraction following IVL therapy is associated with greater increase in coronary artery compliance, and change in coronary artery compliance is an independent predictor of stent expansion.
Thank you, Federico. That was great. And I think to me, the central question of your work is trying to describe an objective metric that we can use to calculate vessel compliance, right? So coronary calcification is very frequent. We have a lot of tools to modify calcium, but we never know when enough is enough. So if we leave insufficient calcium preparation, then we end up with underexpanded stent, which is not good. But if we try to pursue very aggressive preparations, then we might increase the risks of vessel perforation and dissections and so on. So Ziad, what is your first reaction to this new tool? And if you can tell us how you practice now, how you test your vessel compliance, how you decide when to stop with further calcium modifications.
Thank you, Daniel, and really excellent work that I think is the segue into studying this in much more detail and really diving down into the nuances of this. So at the moment, what we have really two tools to be able to determine whether or not we have adequate lesion preparation. One has always been considered to be the presence of calcium fractures on intravascular imaging. The second has been a complete balloon expansion with a centralized wire and equal amounts of contrast on both sides of the wire. Both have a synergistic benefit. But let's talk about the potential caveats of each of those. One of the major caveats with intravascular imaging assessment of calcium fracture is that the data we have so far, which is really based on OCT, is that OCT misses 50% of the fractures. And the reason this happens, of course, is once you've used intravascular lithotripsy, you may have cracked the calcium, but you may have not displaced it. So the analogy would be if I take a glass and I put a crack in the glass, the refraction of the light through that glass may not change because of the crack. And so as a result, we miss 50% of the fractures. If you remember back to Disrupt CAD3, there was no difference in the minimal stent area between patients who had fractures and didn't have fractures. And that's hard to understand if your primary mechanism of efficacy is based on calcium fracture. That was really the nidus for us investigating whether or not OCT creates fractures. One of the caveats to the current study is that we don't know whether IVUS misses fractures, and we don't know how many fractures IVUS misses. This is an area of investigation and actually a planned experiment next month that we're going to perform at CVPath and help us understand with a direct comparison of OCT, IVUS, micro-CT, and histology to see how many fractures we're missing. It is, of course, very interesting in the current study where they find the identifiable fractures when we see the fractures that there's an improvement in compliance. And I think this makes sense, right? If you're able to crack and displace the calcium, you're able to liberate the difference between the systole and diastole. So I think it's definitely an exciting new tool. I did want to clarify with the investigator the methodology. So the compliance was based on co-registered images of pre and post IVL on the same pre and post IVL on the same cross section in systole or diastole, or a mean of those two.
Thank you for the question. This is one of the limitations of our study. There are many limitations because it's quite a novel concept, of course. But we didn't do co-registration. So this is quite a problem. We have a EKG gating. So basically we try to correlate with EKG. That is not ideal, of course. And basically we repeat the measurement in systole and diastole multiple times, try to focus mainly in 360 degrees calcification there to analyze. I don't say easy, but easier. So we exclude calcium nodules or maybe imaging that were sub-optimized, and so we from our registry pertinent for inclusion were about 20% because we wanted to have clearly good images. But I do confirm and I completely agree that the absence of co-registration is a limitation that can be overcome.
Right. So I think from a scientific hygiene point of view, it's very, very important to standardize the amount of calcium. So if I was to repeat or perform a similar study, I would only include patients who have 270 degrees or more of calcification in the study. And the main reason is, of course, it's much harder to fracture if you have 110 degrees of calcium than compared to 360 degrees of calcium. When you have circumferential calcium, the mean number of fractures by IVL is actually 2.8. When you have less than 180 degrees of calcium, your mean number of calcium fractures is 1.3. And of course, you're correlating calcium fracture to your compliance, so hence you need a standardization on the amount of calcium. And I'm glad it's not just angiographic. So we're learning a lot in this space. And so I think there's an unquestionable benefit to improving the compliance of the artery, not only to help stent expansion, but we recently published that hinge points in the artery are niduses for the development of further calcified lesions, calcified nodules, and restenosis. And we know that if you place these long 38 millimeter stents into stiff arteries, the edges of those stents become at high risk. And so one of the things that the compliance improves is creating a much more smooth rheology.
Yeah. So I think, Zia, you touched on so many great points. And let me go back to the fracture, the prevalence of fracture. So you pointed to the Disrupt CAD3 study, where, if I'm not mistaken, OCT saw fractures in 65% of the lesions. And in the current study, using IVUS with the 20 megahertz catheter, so which is the lowest imaging resolution tool we have, fractures were seen in 75% of the cases, right, Federico? So there is a huge discrepancy of the amount of fractures that we're seeing with a much lower resolution as compared to OCT. My understanding, and I would like to hear your thoughts on that, Federico, is that one, imaging was done on a segment with the maximum calcium, which was always 360 degrees. So the likelihood that you're getting more fractures is higher. And the other, something that came to my attention was that high pressure predilatation was done in 75% of the lesions before IVL. So probably some of those fractures were created by this predilatation, and it's hard to kind of separate what is the actual effect of IVL in those cases once you mix, predilatation with IVL and then you image. So drive us through, the timelines of your procedure, how these images were done, and all cases were imaged before any balloon dilatation, or you have predilatation allowed before the first IVUS run was done?
Yeah, thank you very much for this question. So this is something I missed to mention before. So the IVUS was performed just before IVL. So we inflate, as usually, we inflate a non-compliant balloon. Later on, we run IVUS and then IVL, and just after we run another IVUS. So to obtain an imaging before non-compliant balloon, because could be also a confounder. I would like to mention that basically we use IVL registry because we have a big registry in Europe regarding IVL, but this is a concept that can be also expand to other tools. Could be cutting balloon, could be non-compliant balloon. So the next step that we are going to test if IVL is superior to non-compliant balloon in terms of modification of coronary compliance is something we are working a little bit more. So, but to answer to your question, yes, we, besides limitation that we already mentioned, we try to be consistent in select cases with 360 degrees. So it was also easier to check for calcification. So also the incident calcification probably were higher, and we run the IVUS just before and just after IVL.
You know, what are the predictors of not developing fractures in 360 degrees of calcium? You know, I can tell you with IVL and 360 degrees of calcium to not get a fracture is very unusual. And so most of the time that's because the minimum calcium thickness is very, very thick. Not very thick, very, very thick, approaching a millimeter. And so one of the reasons you're going to have reduced compliance in those vessels, of course, is that the calcium is so thick that you're even to regain compliance is going to be very, very challenging.
Yeah, I think that's a reasoning for the revised OCT scoring system. Now you're looking at the minimum thickness as opposed to the maximum thickness. I think this explains a little bit of that.
It's an interesting point, Daniel, because actually it was always the minimum thickness, and it was an error that we missed in the Eurointervention paper. And it was unfortunately lost in translation that it said maximum thickness. It was never meant to be. Of course, your predictor of fractures always minimum.
Always minimum, yeah. Yeah, no, that's a good point. So you also mentioned, you made the analogy from breaking a glass based on the Disrupt CAG 3 study. And based on that study, we learned that if you don't have fractures, you still have the same expansion after you do IVL. So you have been educating people on how to use angiographic enhancement tools to check the balloon expansion, the centralized wire, and contrast on both sides, but that complements the lack of visible fractures by imaging. So my question is, should we still be pursuing fractures when with some sort of calcium modification, or we should really be incorporating other forms of checking for vessel compliance and proper expansion?
Great question. So I can simplify it from my research in this way. The presence of calcium fracture following IVL on intravascular imaging confirm your vessel is ready for stenting. The absence of calcium fractures does not refute that you are ready for stenting, but you need another modality to confirm. And an excellent modality is using the angiogram and looking to see if you have a centralized wire with equal amounts of contrast on both sides. Because the physics of this are just in your favor. Anytime the wire is centralized and you have equal amounts of contrast, by definition, the lesion has to be prepared. And so as a result, if we add that to our modality, add that to our screening tool, you can actually gain a lot more information. You could make the argument, Daniel, that you don't need the intermediate run in that case to look for fractures. And I actually believe that's true. The incremental value at this stage is largely academic.
Yeah. No, that's a great point. And it optimizes the workflow and saves time during the procedure and unnecessary instrumentation. So let's now talk about, you mentioned the minimum thickness. So whenever we have a fracture, we always mention the presence of fractures and how many fractures we're seeing, but we don't have much quantification about how big is the fracture, how deep should the fracture be. So you mentioned calcifications that are very thick, like close to a millimeter. And if you have a very superficial fracture, is this making some effect? So probably this also speaks to what you're saying, that only the fracture doesn't help much on the decision making, right?
So it's a great question, and I can give you a little bit of data on this. So in Illumian 4, which was just published in European Heart Journal this week, when we looked at the difference between the angiographic guidance and the OCT guidance, what we noticed in the post-PCI assessment is that there was more partial fractures in the OCT guided group. And so if you think of this going back to the analogy of the cracked glass, right? A cracked glass is clearly weaker than a non-cracked glass. So the only thing that's separating the cracked glass from breaking is high pressure dilation. And so I do believe that these partial fractures are actually very beneficial. And another great analogy to do that is, imagine you have a windshield, the windshield of your car, right? If you have no cracks in it, it's very, very hard. But once you develop the first crack, you've actually started the pathway to change the compliance, because one crack leads to a bigger crack, which leads to a bigger crack. And finally, at one point, you're going to be able to push the whole windshield in. So that change in compliance, that first crack actually sets a chain reaction downwards to create an improvement in compliance.
Yeah, no, that's great. So do you think the lack of association that Federico found with these coronary compliance changes in non-fractured vessels, would this be like an incremental? So probably some of those are not visible fractures, but they have this glass effect. So these are weaker vessels, but if we could have this comparison against calcium before modification, so there would be an incremental in change of compliance. So very minimal compliance, a little bit of compliance if you don't see fractures, and more compliance if you see visible fracture.
So another great question. So the predictors of partial thickness fractures are the thickness of the calcium. The denominator between the two is, if you have thicker calcium, number one, it's harder to fracture it. Number two, you're less likely to get a full thickness fracture. And so those, since they both tie into how thick the calcium is, that's the main predictor, I think, of the change in compliance, the thickness of the calcification.
That's great. So looking into the future now, how do you see us doing PCI? Are we still relying on balloon expansion, or do you see these tools or other forms of objectively quantifying, adequate vessel preparation in the cath lab?
No, I think there's potentially tools that could help us with this if we were going to go completely futuristic, right? So you can imagine, and you've seen other of these publications and scientific presentations where they inflate the balloon, and as they inflate the balloon and they create a fracture, there's a change in the atmospheric pressure on the indiflator. It wouldn't be that difficult to actually be able to measure the change in compliance using a pressure transducer inside the coronary. Although, of course, from a practical point of view, we don't have those tools available. Until then, I think the combination of the presence of fractures on intravascular imaging, confirming you're a bit ready to stent, and the combination of high pressure post dilation with adequate expansion and centralization of the wire, they're good tools for us. As we gain more information, like in the current study, about how compliance can change based on the morphology of calcium, we'll learn more about this.
Yeah, so you mentioned something, I was coming close to the end, but I think it's worth mentioning. You mentioned about the indiflator pressure. And so oftentimes we see people asking, how long the inflation should be, how long is enough? And during my career, I always taught my fellows, it doesn't matter how long. look at the pointer at the inflator. Whenever you reach a stable position, that's when you overcame the resistance and you have a stable inflation. So sometimes it can be 10 seconds, sometimes it can be 40 seconds. It depends on the vessel, the amount of plaque you have, and whatever. So I was always targeting the stable position at the pointer in the inflator and checking balloon expansions like in 2 views. I didn't have these very nice way of looking at the centralized wire. That's a very good tip, you know, a very good trick to use, but that's another point, you know, how long inflation should be. So I think everyone has different practices, and I would like to hear how you do it.
Well, I think the data actually, which largely comes from the Japanese studies, suggests that at least a 40-second inflation is the optimal time. And that actually, there's another study on that looking at the same concept of compliance, that if you give the vessel enough time, like any muscular object in your body, whether it's why do you stretch? It's the same concept, exactly the same concept. Any, you know, orifice or sphincter, always it needs time to stretch. And so as a result, the coronary arteries really are not that different. It's as part of their, you know, muscular or elastic arteries. You need time. What's interesting about this is that I think that we've been studying this in drug-coated balloons. And so while, you know, the IFU for drug-coated balloons says that your inflation time should be between 30 and 60 seconds, we've been doing 3 minutes, largely based on data in the periphery that the max amount of drug is removed after 30 minutes. And Daniel, you'd be extremely surprised to look at the difference in the minimal lumen area after your lesion prep and after your 3-minute inflation. It is dramatic. It gives really the artery time to be able to expand. And so we're actually prospectively collecting our data from AGENT, which we had a large population, and now our commercial cases to show that these longer inflations actually lead to an increase in minimal stent area. There's actually one paper from Japan with 800 patients that showed the optimal timing for drug-coated balloons is more than 180 seconds for ISR.
Oh, that's great. That's great. So Federico, how you see us using this tool in the cath lab moving forward? So I see, you know, some practical limitations to that. One is the absence of triggering. So it's very hard in the cath lab, if you have a stationary IVUS recording, to find visually the end diastolic phase and systolic frame. That would be one practical limitation. The other is that this analysis was restricted to the maximum calcium arc, but sometimes, you know, you have long lesions and very heterogeneous calcium distribution. You may have, most of the times, eccentric calcium. So we're not checking, and we don't know how these tool works for eccentric calcification, calcified nodules, and so on. So what is your final thought about how people could incorporate these into their clinical practice?
Yeah, thank you for the question. So yeah, as I mentioned before, this is a quite novel concept. And basically, we were thinking also about which could be the clinical implication. In my opinion, the clinical implication would be also to limit complication. Why? Because one of the problems in PCI, of course, is lesion preparation. But nowadays, we have a lot of tools to treat almost every lesions, I would say, and sometimes also over-treatment or over-preparation would be also another issue. So to have a number, in this case, a coronary compliance modification, that could be also a percentage that we didn't check yet compared to the baseline, will tell us maybe which is the threefold for that specific lesion that allows us to place a stent without further plaque modification. As Professor Ali told before, it would be nice to have an intelligent balloon, we could call an intelligent balloon, to measure live instead of performing IVUS all the time. But also every lesion is different. For example, treating a ostial lesion on left main is completely different because you have also the compliance of the aorta, or right coronary artery is completely different from LAD. But once again, this is a novel concept, and I'm very glad there are limitations because it means we have margin improvement. But basically, my focus would be also to limit the complication like perforation or also advanced dissections.
Oh, that's great. So with that, I think we can wrap up these conversations. It was great. Thank you so much for presenting your results and submitting your research to JSCAI. And Ziad, thank you so much for being with us, for sharing all your knowledge and new data on this interesting topic. Thank you so much, guys.